Hello, classmates and Dr. Cooper. Tonight I will be presenting my project. I chose to do whooping cough, which is also known as pertussis. And here we go. Whooping cough. So first we're going to be talking about the pathophysiology related to this disease process. And basically what happens is that this bacteria called Bordetella gets into your respiratory tract and it attaches itself to the cilia that are found in the lungs. The cilia are basically, it's kind of like hair, but they kind of flow back and forth. They move. They kind of remind me of a sea anemone on a coral reef in the ocean, and they just flow back and forth, and they help with movement in the respiratory tract. Anyway, so these Bordetella, they attach to the cilia, and they create these toxins that eventually end up creating the cilia to stop moving, paralysis. And then this results in inflammation in the lungs, which is not comfortable, and it's hard to get the mucus and other secretions that you have in your lungs out. So that is the pathophysiology. And then this little corner here, I googled a picture of what the rods look like. So that's what you got there. Modes of transmission, I thought this was really important to add because it can help in stopping the spread of the disease process. So basically, it's transmitted by air droplets and direct contact. And when I say air droplets, I mean if somebody sneezes or coughs, then those droplets, those little particles, they can travel quite a distance. And that's how we can contract the bacteria. And direct contact, if you're cleaning up after someone and they've been blowing their nose or they've been hacking up the mucus from their lungs, they may have the bacteria in those tissues. And if you touch the tissues and then touch another child, that's another mode of transmission. But the most common mode is by coughing or sneezing. And I mentioned the child factor because this disease typically impacts younger children, but it's not limited to kids. Okay, so the prognosis, I thought this was a really nice chart that the CDC had because whooping cough comes in 3 different phases. The first one is the catarrhal stage, the second one is the paroxysmal stage, and the third one is the convalescent, and each stage has different symptoms and accompanying factors for each one. So the first one, basically this will kind of seem like a common cold, a low-grade fever, an occasional cough. Apparently at this point it's very contagious. And it seems like here you may or may not decide to get treatment because you may try and just wait it out. So that's kind of the problem with this stage. And this lasts for about 1 to 2 weeks. The second stage is the paroxysmal stage. This lasting for 1 to 6 weeks, but as long as 10 weeks. And this is kind of where the whooping cough comes into play, becoming very tired and coughing so much that you may vomit, which obviously would be uncomfortable. And between the coughing and the vomiting, it basically exhausts the patient, and it makes it very hard to sleep at night. Stage 3 would be the convalescent stage. And this is approximately 2 to 3 weeks long. And basically, during this time, your body is recovering, you're coughing less, but you may have a return of the cough. So it's kind of like hit or miss during this phase, but it's basically on a downward trend. So that is the prognosis of this disease. What to expect? So for parents or individuals that may think they have it, or for clinicians, this part is pretty important. The physical assessment findings. So obviously your patient is going to be coughing quite a bit. And that does kind of depend on what stage they're in. So like I said, if they're in stage 2, which is the paroxysmal stage, they'll be coughing. They may see cyanosis of the lips because they're not able to catch their breath when coughing so hard. You may notice that they're dry heaving or even vomiting at this stage. You may see bruising or even the hemorrhages in the conjunctiva of the eye, and that's because the coughing is so intense. You may or may not see a fever, and if you do, it will probably be low grade. And when auscultating the lungs, apparently you have clear lung sounds, which I wasn't expecting that, but doing my research, I guess that's a common finding. And that will help to differentiate whether this is whooping cough or pneumonia, because with pneumonia you'll have crackles or kind of like a wet sound. So you can kind of base that on your diagnosis when thinking of your treatment for the patient. Diagnostic findings. So the best absolute way to test for whooping cough is by culture. And you basically will have a swab that'll go in the nasopharynx of the patient. And ideally, you'll want to do this within the first or second week of them having symptoms, because that's when it's most accurate. And clinical presentation, I kind of touched on that. And again, that really depends on what stage they're in. You want to see the patient as soon as you can, because you want to be able to diagnose it accurately. You want to be able to decrease their symptoms as much as possible and then get them started on their antibiotic treatment, because you don't want to have complications. Pharmacological treatment. So what medicines are you going to give this patient? I found that macrolides were basically the chosen class for antibiotics to be used, and this includes azithromycin, clarithromycin, and erythromycin. Basically, these are safe to use in your younger population and as well as your older population, which is good. And if you need an alternative, then you have this option here. It says 2 months and older. Okay, so it's still for your younger population. So I guess if you have an allergy or a contraindication, drug interaction, one of those things, then you can resort to your other option. So some considerations for macrolides as a class. I wanted to focus on the class because it seems like there's a variety of medications within the class that you can use. So instead of focusing on just one, I just kind of combine the class together. So macrolides, they basically attack the bacteria by attaching to them and inhibiting the protein synthesis process, and they need that to survive. So they're killing off the bacteria, which is good. Some contraindications for this medication are really kind of cardiac in nature, which this is new to me. We prescribe in the ER that I work, they prescribe azithromycin and macrolides in general. They prescribe that quite often, and I never really thought about the cardiac issues that are related to them. But some of them include prolonged QT intervals, QT syndrome type 2, taking class 1A or 3 antiarrhythmic drugs. If you're pregnant, you have allergies to the medication, or if you have a known resistance to the medication, you want to kind of steer away from this class of drugs if your patient falls into one of these categories. Some adverse reactions and side effects include nausea, vomit, diarrhea, abdominal pain, cardiac arrhythmias, hearing loss, and I saw that could be reversible, but sometimes it's permanent. So Stevens-Johnson syndrome, and pyloric stenosis, which occurs in newborns. Some implications for use for this class of drugs includes pharyngitis, pneumonia, whooping cough, gonorrheal infections, chlamydial infections, COPD, and some skin infections as well. So it has like a broad use, which is good. Some important information for medication administration and disease process of pertussis. As a clinician, you want to be sure to get a baseline EKG on this patient. That's really important because if you have a follow up with them, or if they call you for a concern and they come in a little bit earlier, you want to get an EKG at that point too, but you want to be able to compare the two to make sure that the medication is not, creating any kind of arrhythmias that are new or worsen. So that's very important. And also assessing electrolytes for calcium, magnesium, and potassium, because we know that these electrolytes have a huge impact on the heart and can also play into causing arrhythmias. So you don't want to have an electrolyte issue along with the risk of the medication causing a cardiac problem. Cultural acknowledgments for the clinician. I'm sorry. So depending on who your patient is, where they're from, you want to be sure that you all are on the same page as far as language is concerned. If you have to use more simpler terms, you don't have to go in there and prove, that you have this kind of degree and that kind of degree. You want to speak to your patient very simply so that they can understand it, and in the language that they're comfortable with. If you have to get an interpreter, then you can get an interpreter. You really want them to understand what's going on with the disease process and how to properly treat it. And you also want to incorporate some of their cultural beliefs, because some people, they're very big on religion, spirituality, and these have different rituals that come along with it. So if they believe that these rituals will help to heal them, then you want to be able to incorporate that into their treatment plan. So that's kind of a respect factor. So I think that's really important. Lifestyle or behavioral changes for the patient. Um, just some small little tidbits for their recovery that will aid in their recovery. And this would include eating small, frequent meals. And you want to make sure that you tell them to eat after taking the medication, okay? You don't want to take it before, especially with the macrolides because of the GI irritation. Be sure to rest in bed. If they need to call out of work, if they need a work note, then we should be accommodating of that and have them a work letter or a work note. Be sure to take in lots of clear fluids to avoid dehydration, because they may be vomiting and are also just exhausted in general. I'm sure coughing burns quite a bit of calories. And also, you can use an humidifier, and this will help to kind of put some moisture into the air and just kind of coat their lungs and their airway just to make it a little bit more comfortable. So you also want to ensure that the patient is going to adhere to the drug medication and treatment plan in general. So I think it's really important for your clinical staff to check on the patient every few days, whether it's that or every week. You can kind of decide what is best for the patient before they leave, and you want to check on them to make sure they're not having any allergy symptoms, adverse reactions, and this will kind of help to prevent any adverse events from occurring or hospitalization. That's definitely what you don't want to do. Psychosocial and socioeconomic acknowledgments. I mentioned before this disease typically impacts the pediatric population. So communication with the caretaker, you want to make sure that they are ready to learn, they're able to learn, they have the capacity to learn, and whatever the answer to that is, you want to be sure that you can accommodate what they need. If they're an older individual, you may need to have a large print of directions, very clear, using layman's terms. Also, if they're an elderly patient and they have a younger caretaker, like a son or daughter, niece, nephew, something of that nature, you just want to make sure that all parties are on the same page. Okay, so everybody's following the same directions. Let's see. Also, finances, socioeconomic status. Antibiotics can sometimes be a little bit expensive. I actually went on GoodRx before I started recording this to see how much azithromycin would be. And with the coupon, it brought it down to $9.02. And while I thought that was a good price, $9 to me is acceptable, while $9 to somebody else could be a fortune. You know, they might be having to choose between medication and a meal or a bill or something of that nature. So you can't just assume that that will work for them. You have to communicate with them and make sure that they're able to afford it. And if they can't, then you need to use some other resources because they need the medication. So, you know, you can't really budge on that. You need a medication, so it's our job to help them figure out how they can get it at a very low cost or perhaps for free. Oh, here's another picture I really liked from the CDC website. This is a huge component of this disease process, which is vaccinations. You want to get your loved ones vaccinated. The little ones, you have 2, 4, 6 months old, all the way up to your older adult population. If for whatever reason they cannot get a vaccination, the important part of this whole process is to create herd immunity. And so what that basically means is that the surrounding population or community, they're all vaccinated. So the risk of somebody actually getting pertussis is probably fairly low. So that means the person that is not able to get vaccinated also has a lower probability of contracting disease because it's not even in the area. Um, so that's something to pay attention to. Make sure you're up to date on your vaccinations, and you want to be sure to educate your clients on when to do that. Um, and the last thing I wanted to, okay, here's the reference page. And I also have, oh, here's the Word document of the references because this is formatted correctly. I'll attach that to chalk and wire. But I wanted to I wanted to show what whooping cough sounded like because I've never heard it before, but apparently it's very, like you'll recognize it if you hear it one time and know what it is. So I think it's pretty important. And here's just a very short clip of what it sounds like. So that's what it sounds like. Um, Hopefully I'll remember that. So when I start, you know, practicing, I'll be able to identify what's going on. Anyway, that is my presentation on whooping cough. I hope you enjoyed it. If you have any questions or concerns, please let me know. I'll put the URL on the cover page. And stay safe. Keep your hands washed. Social distancing.